All right, everybody, we're going to get ready to get started. So again, we want to welcome you to our very first of a series of three conversations for caregivers. So I'm Chiara Clayton. I'm with the Area Agency on Aging. And we at the Area Agency on Aging, one of our primary roles is to really make sure we empower and inform family caregivers. So in this virtual space that we're in, we wanted to make sure we provided content to family caregivers that can hopefully be beneficial to them and informative to them and help them, because as we know, caregivers are some of the greatest people in the world, but they need assistance and help. So that's what we're here for pretty much. So today's event is really going to be all about speaking about hospice, which is a topic that family caregivers definitely need information on. And we're very proud and very happy to have Hospice of Michigan as our speaker today. So you're going to get a lot of good information. We welcome questions, but what we're going to do is we're going to actually hold our question and answer period for the end. But you can feel free to put any questions in the chat as they come to you during the presentation. And then also, if you're watching on Facebook Live, definitely feel free to leave a comment with a question. And then once our speaker is done, we'll be able to go ahead and take those questions. So here's what we're going to do today. Officially welcome to this webinar. Our presenter we have today is wonderful. Her name is Miss Bethany Westrick of Hospice of Michigan. So she's going to give us a very informative and engaging webinar today on behalf of the Hospice of Michigan. After she's done, we're going to have a question and answer time where hopefully we'll be able to get to everyone's questions. And then a little surprise for everyone. Thank you so much for registering for this. So we're going to actually give you something or let you win something at the end. So we're going to have a prize drawing, but you have to stay to the end and be present to win. And we have two $25 gift cards to Amazon that one of you can walk away with today. And then we're going to have a wrap up. So that is what we're going to do today. Again, thank you so much for joining us. And with that, I'm going to introduce our speaker. So our speaker again today is Bethany Westrick, and she is a navigator for the North Star Care community, including Hospice of Michigan, Arbor Hospice, and North Star Palliative Care. Previously, Bethany held roles at Arbor Hospice as a provider relations representative and hospital liaison, as well as with Henry Ford Health System in nursing education. Bethany has a master's in gerontology and wellness management from Ball State University and has a certification in health coaching and is an advanced care planning facilitator. She is passionate about health education, patient-centered care, and end-of-life decision-making. So with that, I am going to throw to our speaker, Ms. Bethany Westrick of Hospice of Michigan.
Thank you so much, Chiara. I am going to share my presentation now. And let's get this moving. All right, hopefully you'll be able to see my screen okay. Everything's good? Yeah. All right. So Susan Kuhar is also on the call. You should be able to see her in the attendees. She's an advisor with Hospice of Michigan. She's the one who helped coordinate this with Chiara today. So really quickly, I just want to state kind of our goals. So today we're going to discuss the Hospice Medicare Benefit, also talk about what palliative care is and kind of what our program looks like in our organization, as well as discuss any type of advanced directives and barriers and limitations that might come up for patients and their families. So this is the time that we're going to launch our first poll.
Okay.
And Chiara is going to launch that. So take a moment here. So my first question is more of a understanding. I want to see where you are with your understanding. So why should one utilize hospice and or palliative care? The first question answer is, I'm unsure if I want aggressive treatment or want to focus on quality of life. Another option is for empowerment to live out my last days, weeks, or months the way I want to. The third option is for assistance making decisions for myself or others when I'm unprepared and don't know what to do. And the last is assistance for patient, family, and friends through the dying process, helping provide symptom management and continued support for my family after I die. And we're gonna give it a little bit, let everybody have an opportunity to vote.
And if anyone is looking for the poll section, it should be at the bottom of your screen. It says polls. You can click that and then you'll be able to cast your vote. And pretty much we got about 80% of people who have already voted. So we'll give everybody a couple more minutes. Almost 100%.
This is great. I think we just have a few more that we're waiting on.
Yeah. So we'll give everybody about 30 more seconds to cast your vote. All right. Okay, here we go. So now we'll share the results.
So everyone was actually right. The answer is all of the above for this one. Hospice is, and palliative care is not only for people who are actively dying to help with symptom management and also grief support and other support for family after they die, but it's also in helping to make decisions for both yourself as the patient and also to help guide decisions based on what your goals are. And also to help when you get to that pivotal decision of, whether you'd like to continue receiving aggressive treatment or you're wanting to focus on quality of life. So thank you for sharing all of your answers. And I think I can just close that there. All right. It's not, okay, there we go. So I want to start by looking at the traditional medical model. So when one typically would go to the doctor's office, and maybe this was even more true in the more recent past, let's say in the early 2000s, but we would focus on prevention, on health maintenance, and then we would be diagnosed with some type of very serious disease. And we would have this time where we would be sharing the curative and life-prolonging care, where we do everything. For instance, someone who has a cancer and we throw chemo at them and radiation. And, we look at any type of medication that we can to manage symptoms. And it gets to the point where, or it was to the point where they would say, okay, well, there's nothing more that we could do. That's when you sign on to hospice. Right after that, death would occur and then bereavement for the family. And that has changed. Palliative care, which is not a new concept, but does seem to be a relatively new practice, came about really in this area. It seemed to be practiced most prevalently in the 1970s and moving forward. But the goal of palliative care is to help prevent and relieve suffering. It's accomplished through effective management of pain and other distressing symptoms that also incorporates psychosocial and spiritual care based on what the patient believes and what their needs and their values are, and also taking into account what their culture is. So we're not just looking at the traditional disease model anymore. We're looking at enhancing quality of life. The focus is very much on optimizing function and helping with decision-making. And we know now that this can be accomplished at the same time as life-prolonging care or as the main focus of care. I think that there's more and more people that are looking at how their care is being delivered to them, and they're making a choice on how they want to move forward and not just kind of taking that recommendation from a physician and saying, okay, well, this must be the only way because it's the only thing that's been presented to me. And instead saying, the most important thing for me is if I, am able to still walk my granddaughter down the aisle, or to perhaps do something else like, as long as I can continue to toilet myself independently, I still feel like I have good quality of life. So our goal is always in the hospice and palliative realm to meet the patient where they are and to find out what's most important to them. So this new continuum of care, still starts with prevention and education. And then, as you can see, at the time of diagnosis, we start looking at curative and life-prolonging care as happening at the same type of time as palliative care. Symptom management, we start talking about life closure. So maybe things that one did that they wish they wouldn't have done. Maybe they have some family dynamics that they'd really like to work through, and it would help them feel more at ease if they could, solve some of their problems that they've struggled with. And as you can see, as we move into like the end of life and dying process, that's still happening sometimes at the same type as curative and life prolonging care, but generally it starts to taper off as we get to the end. And then again, after death, we would have the bereavement team come in. So often as well, I should mention that the bereavement team isn't only active at the time of death. We often have families that are suffering ahead of time and are really struggling with the impending event and need more support than they're currently receiving. And so our bereavement team often will step in ahead of time before the patient passes and is there to help support patients and their families before death. So palliative care is a subspecialty of medicine, like any other medical specialty. So like one would go to the cardiologist or the oncologist, the palliative care team is a separate team. They're an extra layer of support in addition to your current medical team. They're not going to replace your cardiologist or your primary care physician, your internal medicine physician. They also don't place any limits on the type of care you can receive, but their big piece is symptom management and focusing on quality of life. So, and again, that quality of life is dependent on what the patient says quality of life and there are two different types of palliative care services. There's a hospital-based, which some people may be more familiar with. Sometimes they have a palliative consult when they're in the hospital. And then there's also a community-based program, similar to what our organization does, that serves patients wherever they call home. So places like skilled nursing facilities, in independent living, in their own home, in their apartment, anywhere that home is for them. So again, this is a big picture team. Usually it's a nurse practitioner or a physician. It could be a PA, as well as a physician that's overseeing them. And they often have other components as well, a social worker. Their point is to help with advanced directives, as well as that symptom management. And also in the end, sometimes it helps saving the patient and family money, which I know everybody enjoys. But when we're looking at kind of skyrocketing health costs and getting closer to end of life, sometimes palliative care can be a very welcome reprieve because it does help patients and families evaluate what's working for them, what isn't working for them, and also help kind of put a focus on how people want to move forward, which could help reduce some costs in a scenario where they might be saying, okay, well here's these 5 options, and these 2 will probably give you the best results, and this one might give some good results, and these 2 probably are a Hail Mary, but there are options. And so it could help narrow down the focus. So some of the symptoms that we're looking at in addition to pain are things like fatigue, constipation, anorexia, mood disorder. Oh, it looks like I have fatigue on there twice. Sorry. It's really important to us that you're not fatigued, apparently. these are things that happen with a lot of different illnesses. So this isn't necessarily illness specific. It's not just people who have cancer, which I think that that's maybe a lot of what people think that hospice patients have, is that they have cancer. But in reality, we see not just cancer patients, but we see lots of patients that have COPD or they have heart failure. We have lots of patients that have dementia and things that are related to their dementia. And so, it's not just, fatigue. It's things like with dementia, for instance, it could be agitation. As someone begins to realize that they're forgetting, but their mind is still there enough that they are aware that they're forgetting, and they start to get very frustrated. Sometimes we see a lot of agitation, especially as caregivers change, that families might bring in outside caregivers to help reduce some of the burden that the caregiver is experiencing. And so that agitation creeps up a lot. And there are a lot of different ways that we can help manage agitation, not just with medications, but also with certain approaches, just in how we speak to patients, or helping them find calming activities that are meaningful to them. And sometimes there are things that you think, oh wow, I could have thought of that, but if you hadn't seen 30 other hospice patients that week, or 30 other palliative patients that week, it might not be something that you're thinking of. We are the experts that come in and help with these pain and symptom management things. And we want to make sure that you guys have all of the tools in your toolbox to be able to help care for your loved ones at home. So we don't talk a lot about studies because, number one, I think that they're sometimes really confusing to read, but this one is really clear. This was a study that was done on metastatic non-small cell lung cancer, specifically for stage 4 patients. And this is like one of the most aggressive types of cancer that one can have. And so it's significant that we look at this one. When they started this study, they had 151 patients who had a new diagnosis of a stage 4 metastatic small cell lung cancer. And at the time of the diagnosis, the patient was either randomized to have palliative care integrated into standard cancer care, or just have standard cancer care alone. And what they found was that the group that had palliative care integrated into their standard cancer care had less symptoms, that they reported a higher quality of life, that they were more likely to have discussed their preferences for end-of-life care, that they received less aggressive care, and that they lived for almost 3 months longer. So this isn't that they stopped having certain types of curative treatment. They were still receiving the same types of care that everybody else was getting, but instead they were having more symptom management, that they were able to discuss what type of care they wanted to have for themselves and make sure that their goals were still aligned with what was going on, and that they lived longer. I think that that's like the most significant part. I think that a lot of people are concerned about starting palliative care thinking, oh, well, I'm going to die sooner. But that really hasn't been what we're finding. These results were really definitive. And I think that this was a starting off point where they started to look more at what palliative care could do for patients that had these serious terminal diseases. So for patients that are thinking that they might want palliative care, there's a couple of things that I think are probably the most important. So they probably have some uncontrolled physical symptoms that are related to a serious illness and or its treatment. So things like having chemo or radiation, or maybe dialysis, things like that. that the patient or their family is experiencing emotional or spiritual distress regarding their diagnosis or prognosis. And let's be honest, how many people get a diagnosis and they just say, oh, yep, everything's fine. I'm fine with this diagnosis. I know what's going to happen. There's not many people, right? Most of us turn to Google as kind of a first step. I'm not saying don't ever Google, because it can be a good thing, but having a palliative care team to help answer these questions and give you a more realistic expectation of what things look like is really helpful. You may have accelerating need for medical care or hospitalizations. That's one of the things that we ask when we talk to patients and families, like what does your care look like so far? If you've been in and out of the hospital multiple times, trying to help with symptom management, or, if you've been doing okay at home on your own, if you've been making a lot of doctor's appointments, if you've been on the phone with your doctor every day, these are all types of things that we want to help with. And then lastly, I want to mention that sometimes, we get to the point where we're no longer able to eat or to drink, or they may be discussing putting in a trach. And these are all things that we are able to help you formulate your feelings and thoughts on by giving you kind of pros and cons and letting you know what the outcomes look like. For instance, for people who are at an advanced age and have, these end stage diseases, if they're at a point in their disease process where they're towards the end, CPR may not be effective for them. And I'm not saying might work. It probably won't work at all in a lot of instances. And so, having the conversation ahead of time on whether you'd like to have CPR or not could prevent a lot of other steps being taken ahead of time to help your care be more streamlined and be more in line with what you're wanting for yourself. So then when we start talking about palliative care and hospice, people are like, well, I thought, hospice was palliative care, or palliative care is hospice. So there's non-hospice palliative care, which is appropriate at any point in a serious illness. And it can be provided, again, at the same time as life-prolonging treatment. There's no requirement as far as, what your lifespan looks like with this disease, and you don't have to choose between any treatment approaches. Hospice is a form of palliative care. This helps provide care for those in the last weeks to few months of life. Officially, Medicare says that we can provide hospice care to anyone who has a 6-month or less life expectancy. And again, that is not a Hospice of Michigan determination. This is a Medicare determination, because hospice is a Medicare program. So if it helps you to see something visually, this is the palliative care pie, and hospice is just a small part of palliative care. So palliative care is not necessarily hospice. It can be applied earlier across the disease spectrum. Palliative care, again, is not prognosis dependent. It is not just for cancer. It's also for those people who have, organ failures, who have dementias or Alzheimer's, things like that, Parkinson's disease. And it is not in place of life-prolonging therapies or hospitalizations. It's not giving up. Actually, in every sense, it's a formal expansion of care. Like I said earlier, it is in addition to, it's another layer of care in addition to your primary care providers and your other specialists. But what about hospice, right? Because that is one of the things that people want to know about. So hospice is more robust support than a palliative care program would be. It's 24/7 support. So if something happens in the middle of the night and, someone's having difficulty breathing, or they're having a pain crisis, we have staff available 24/7 to help you and your loved one get through this. We want to meet the patient where they are. This is covered completely by Medicare. It's covered by Medicare Part A. And there's an entire team that helps support both the patient and their family. There's a nurse, a social worker, spiritual care, a home health aide, a grief support, and we have volunteers. And the volunteers do many different types of things. We have volunteers that come over to play cards. We have volunteers that come over to read. We have volunteers that take short walks or do, art projects with patients and families. So there's types of volunteers that do all sorts of different things. And in some areas, we also are working on music therapy and massage therapy. And so those are things that are starting to become more prevalent because we see them as important for quality of life. And that really is our big focus for hospice, is focusing on the best possible quality. The hospice benefit also covers durable medical equipment at end of life. So things like oxygen, if they need it, a hospital bed, a bedside commode, a shower chair, wheelchairs, walkers, things like that. So one more poll. How long can a patient utilize the hospice Medicare benefit? And this one, I'd like you to select only one. The options are 2 weeks, 90 days, 6 months, or there's no time limit. We're about 60% in. Let's take another minute. And no one's going to know how you voted. So if you're holding back because you don't want people to know what choice you made, I'll give you another 15 seconds to get that in. All right. And the correct answer, there is a correct answer for this one, and it's that there's no time limit. So earlier when I said that we can offer it to people who have a 6-month or less diagnosis, Medicare obviously has to make guidelines, right, on how we can offer all of this care, because it's a lot of care. But there is no end to that care unless a patient is improving or is no longer declining. So there are patients that graduate from hospice. That's how some people what some people call it, graduation. And we see it as a good thing that you've stabilized or that you've gotten better while you've been on the hospice benefit, and that you can return to treatment that is more aggressive if you'd like to. You can at any time opt out of hospice treatment. There's no penalty to you to remove hospice and to return to palliative or to curative treatments. But there is no time limit. There's not a end date where we say, well, you've been on this for 90 days, so we're kicking you off. That's not a thing. We don't kick people off of hospice. We want to provide care to you as long as you need it and as long as Medicare will allow us. So periodically throughout your stay on hospice care, the medical team will come together, this social worker, this nurse, this physician, and they will look at how you're doing, and they will make determination based on criteria that they're measuring throughout your stay, and they will recertify you for hospice if they can, as long as you're continuing to show decline and continue to need us. And also they believe that in the next 6 months you will likely die, because again, that 6-month window is what the Medicare benefit covers. So and I can answer more questions about that if those come up. So I think My screen froze. Oh, okay. So we're going to talk a little bit about advanced directives next, because this is another thing that I think is really, really important. Before we even talk about palliative care, before we talk about hospice, everybody needs to learn about advanced directives. So these are legal documents that allow you to spell out your decisions about end-of-life care ahead of time. They're a way to tell your wishes to your family, your friends, and your health professionals. And these only take place when you can no longer speak for yourself. So I think that these are important because we don't know what's going to happen tomorrow. And I'm not talking, end of life, well, you can be diagnosed with cancer tomorrow. I'm talking about also sudden events, things like we step out in front of a bus and we die, or maybe die isn't the right word, because then you wouldn't need your advanced directive necessarily. But let's say we're seriously injured and we're not able to speak for ourselves anymore. These types of events happen, and often people think, well, I'm too young for this, or I don't have a, life-limiting disease, so I don't really need to think about that. But the reality is that everybody needs to think about this from age 18 and up. It's really something that I wish that we taught in high school, and that you kind of, when you graduated from high school, you set up your advanced directive. These are the things that are most important to me right now. This is the type of care I would like to have. This is the type of care I don't want to have. Obviously, I think that a lot of 18-year-olds don't have a really great grasp of all of the things that are most important to them at that time. But this is something that can be revisited often throughout your life, and should be revisited, kind of like going for a checkup every year. You should review your advanced directives and say, is this still the person that I think can help make the best choices for me if I couldn't speak for myself? And also, is this still the type of care that I would want? So we'll talk about, there's 3 types, and we'll talk a little bit more about those. So the first one is a living will. If you've heard of 5 wishes, that's a really popular one. That's a living will. It's a written document where you inform your doctors, your family members, and others what you wish to receive should you become terminally ill or permanently unconscious. This, again, only takes effect after a doctor diagnoses you as terminally ill or permanently unconscious, and you're no longer able to make or communicate decisions about your care. So 47 states have given living wills legal force, but Michigan hasn't yet passed a law. Right now, there is a court decision that says that living wills are binding, but it's still a little like wishy-washy. And so right now, no one can provide absolute assurance that your wishes will be honored. However, I think that it's still important to have these recorded, because it gives your friends and family some framework on how to make these decisions. And when we're in a sudden event type of thing where we are probably grieving as a loved one and trying to make decisions based on what you think someone might want for themselves, it gives family members and friends peace of mind to be able to look at these living wills and say, okay, they laid this out right here. They definitely don't want that, but they do want this, or they're open to this. So if we can give them some framework to work with, I think that that's kind of a gift. There's also durable power of attorneys. These are legally binding. They're available online as a fill in the blank, or you can meet with an attorney and write one out. These are also known as healthcare proxies or patient advocate designations. This again is a form or document that talks about medical treatment and how you would like care to be given to you. Lastly, I think that this one is a little bit more serious. This is a do not resuscitate order. So this is also a written document in which you express your wish that if your breathing and your heartbeat cease, that you don't want anyone to attempt to resuscitate you. This is legally binding, and it has to be signed by your physician. So you can't just write do not resuscitate on a piece of paper and sign your name. That is not good enough. Your doctor has to sign this. You cannot tattoo it on your chest. I know that that's something that people have tried to do. that is not a binding document on your chest, unless you can possibly get your physician to somehow tattoo his name on you as well. But I don't think that has happened yet. So DNR has to be on paper, has to be signed by your physician. And it's also helpful if if your physician has a copy, as well as you yourself and your family member has a copy. You should always make sure that regardless of which type of advanced directives you have, that you have them in multiple places. Having them on file at your doctor's office and also with the hospital system that you go to most frequently, that's really helpful. That way, if you were to be in an accident, you are taken to the emergency room, they pull up your chart, it's already there. So you always want to make sure that your up-to-date copy is on file. So in wrapping up, there's never nothing more we can do. The biggest complaint actually is that we didn't have hospice or palliative services sooner. I've never heard a patient or family say, I think that we did this too soon. Occasionally we have people say things like, you know what, I think I still want to try this one other treatment, but I've never heard somebody say, I think we did this too soon. This is a complete change in how a lot of people are thinking about end-of-life care. And I know that it can be scary, but we're here to support you. In the end, I think the most important thing is that you feel well supported in your decisions and that you have all of the information that you need. And that is exactly what we're here to do. So we are here 24/7. You can call the 888 number that's on the screen. Also, Susan is also a advanced care planning facilitator. She's happy to talk to you. Her phone number is there, as well as mine. And I think that wraps things up. If we can open this up for comments or questions.
Wonderful. Thank you, Bethany. And to everyone that is watching, we already have a couple questions in the chat, but if you have any questions, please place them in the chat. We're going to start there. And we'll give everybody a minute in case you did want to ask a question. So again, if you're just tuning in or not really sure what you're watching, you're here with the Area Agency on Aging and Hospice of Michigan for our first of 3 webinars, which is going to be our Conversations for Caregivers series. And today we're talking about hospice care. And we want to make sure everyone gets their questions in. And I just wanted to give some information while we're waiting on questions on the Area Agency on Aging. So we're happy to host this for everybody today. And hopefully you've heard of us, but if you haven't, the Area Agency on Aging 1B, we're a nonprofit dedicated to helping older adults to be able to remain independent in their homes, and to just make sure they have the services and programs that they need. So with that, we have a couple ways that you can contact us. And if you're looking for services, you can give a call to our 800 number or go to our website. And just so you know, we service 6 counties. So we service Oakland, St. Clair, Washtenaw, Monroe, Macomb, and Livingston. So if you live in one of those 6 counties, you're a family caregiver caring for an older adult, or you're an older adult, 60 and over, looking for services that you can possibly utilize, you can give us a call at 800-852-7795. And then we also have our website where we keep a lot of our information updated, and it's a great quick touch base, quick reference to find resources specifically for caregivers. We have a whole section for caregiver resources at aaa1b.org. So again, we're very happy to be here with you today. And with that, I want to definitely go ahead and make sure that we get some questions going. So I'm going to go back to the chat here. All right, let's see. Okay, we're going to start. And if you'd like to ask your question live, please raise your hand because we can take some live questions. Or if you want to just put it in the chat, we can go ahead and have Bethany answer. So first, Bethany, during the presentation, we had someone ask, will the participants have access to your PowerPoint presentation. Can that be shared with them after this is over? Oh, you're muted.
Sorry. Unfortunately, I can't share the presentation, but you will be able to view it on Facebook Live. So you should be able to review all of the slides there.
Yes, and also we are recording this. So everyone will get a copy of this recording as well after the presentation, but it will be available to be viewed, shared, and viewed at a later date on our Facebook Live page and also on the Hospice of Michigan's Facebook as well. So thank you for that, Bethany. Another question, someone asked, why must the document you referenced be signed by a physician? Stu said that's new to her.
The DNR, you know, I can't speak as to what it looked like previously, but as far as I'm aware of, the DNR has always required a physician signature.
Okay. Okay. And Jean asks, is palliative care offered to people with disabilities even though they are not 60 years old?
Oh, absolutely. I think that there's no age limit first on palliative care. This is absolutely not age-based. It's only for people who do have diseases that are terminal. So they may not yet be in that end of life stage yet. They may be in kind of like a step before it, if you will, a pre-hospice, if you want to think about it that way. But it is absolutely available to people under the age of 60.
Okay. And those are the only ones that I see. Are there any more? Let me go to the chat. Does anyone want to ask a question live? You can raise your hand if you'd like to maybe talk directly to Bethany, or you can place it in the chat. And again, if you need to call the Area Agency on Aging, make sure you call us at 800-852-7795. Any other?
I think Sue had one more question about.
Oh, yes, thank you.
Yeah.
Yep.
So you don't act. So Sue says we had it drawn up by a lawyer a few years ago, and the only time I needed it to be reaffirmed by a physician is when my husband was actively in the hospital. So there's a difference between the DNR and the Advanced Directive. The DNR is the one that needs to be signed by the physician, but the durable power of attorney paperwork or the Advanced Directive does not need to be signed by the physician. That's probably the one that you filled out with your attorney. So that one does not need a physician signature, but the DNR does.
Okay, thank you.
I hope that answered your question, Sue.
Thank you, Sue. And Sue, if you have any other questions, please put them in the chat. Oh, I think I see Sam. Are you raising your hand, Sam? Okay, Sam, I'm going to unmute you. Okay. Go ahead and unmute yourself. Oh, you're still muted, Sam.
Am I unmuted?
Yep, we can hear you now.
Is Palliative Care covered by Medicare?
It is. It's covered by Medicare Part B, the same way that a physician would be covered like a specialist, like a cardiologist or an oncologist.
And so what's the criteria for palliative care and Medicare?
The criteria for palliative care is just that you have a life-limiting disease diagnosis and that you have symptoms that you want to have managed, or that you would like help filling out advanced directives. That's also something that your team can help with.
Okay, thank you.
You're welcome.
Anyone else have Sue has her hand raised. Okay, Sue, I'm going to unmute you.
I just typed it in.
Oh,
Okay.
you did. Okay, perfect.
Sue's question was, how do you know when it's the right time to contact HOM? You said in the presentation that people always say that they should have called sooner. Quite honestly, you can call today. If you have a life-limiting diagnosis or you think that someone is getting closer to end of life, it's never too early to call. That doesn't mean that they'll necessarily be eligible, but there are other resources that we can help you find in addition to the Area Agency on Aging. I think that there's a lot of other services that are out there that can help you live more comfortably. There's palliative care before hospice. that's just one of the things in our wheelhouse of things that we can recommend. But our navigators are there to help you navigate the healthcare system as well as this end-of-life diagnosis. So if there's ever a question on whether you're eligible or not, that I would call first and let the team come out and speak with you and talk with you more about what your goals are. And you can always opt not to use hospice right now or palliative care right now, but I think that having the information is more important. So you can always call 888-247-5701, and that gets you directly in touch with the team that will help direct you to someone that can answer more questions for you.
And also too, I see that Sue is asking what's new to Medicare also, so they're not sure what's covered. Area Agency on Aging also has a whole department called MAP, and it's Medicare Medicaid Assistance Program. If you give us a call, we actually have trained volunteers that can give you just a general overview of Medicare, what's covered, what's not, every option as far as Advantage plans, what's the difference between that and the Medigap, just anything you would need to know. It's unbiased, just to give you education so that you can make the best decision for yourself. If you call us, we can connect you with one of our MAP counselors, and you can actually set up time and talk to them one-on-one, and you can connect with them, 800-852-7795. And that's specifically if anyone has questions on Medicare. Our MAP department is awesome. They're ready to talk to you to help you to navigate through that piece if needed. And I see on our Facebook Live, we have Karen who asked, presentation be available on recording? I missed the first portion. Karen, once this is done, you can actually start it over on Facebook Live and watch from the beginning. If you wanted to receive the Zoom link that we're recording right now, I'll place my contact information in the chat on Facebook Live, and you can shoot me an email and I can send this to you after we're done. And everyone's saying, oh, thank you, Bethany. Very well done. That's from Marilyn Lawson, who, by the way, is our next speaker for our second series, which is going to be next month. So Marilyn's going to give a wonderful presentation next month on elder care coordination.
Great.
Oh, and one other question. Oh, and the MAP information is in the chat as well if anyone needs it. Thank you to my manager, Kathleen, for making sure that information's in there. One other question, Quan Ling asks, in the diagram, hospice care is a small part of palliative care pie. What are the others?
That's a really great question. So I think that it can be answered multiple ways. And it's kind of up to you to, to interpret how you'd wish. But when I think of it, I think of the time limit that is kind of limited to hospice, so that 6 month or less diagnosis. But and that palliative care can, serve you for much longer, as far as the amount of time that one may have left before end of life. But one could also look at it as, this is a smaller percentage of people who are on hospice at end of life, and that more people are on palliative closer to the end. I'm not sure if those are the answers that you were looking for, but those are my best guesses.
Awesome. Okay, thank you. And I believe those are all the questions. Hospice of Michigan's contact number is also in the chat in case anyone missed that. You're going to get an email from us with some kind of wrap-up information and things that we want you to have going out of this after this presentation is over. But I promised that we were going to do some giveaways. I don't want to, make everyone wait too long. So we have two winners, and I believe they're still with us. So Janelle Williams and Carl Smith, you are winners of a $25 gift card to Amazon. I believe they're still on. Yes, I see Carl and I see Janelle still with us. So perfect, that worked out. So look for an email. You're welcome, Carl. You're welcome, Janelle. Look for an email from me with those gift cards. And just lastly, before we wrap up, again, Area Agency on Aging 1B, We're so happy to be here with you today to be able to present this information on behalf of Hospice, or with Hospice of Michigan. We want to definitely thank them for partnering with us on this. This was great information. We hope that everyone here found it helpful. And we hope that, you know, if you need anything, definitely give them a call. If you need any services in reference to just general family caregiver needs, older adult needs, please contact the Area Agency on Aging at 800-852-7795. We have a lot of good webinars coming. One is actually going to be 2 days from now, and I'm going to try to, I created a slide for it, so I figure maybe I'll show it. But if you're interested, and I know a lot of people are, on the COVID-19 vaccine. So we have a lot of information that is being asked about that. I know that our resource center is getting tons of calls. We are hosting a COVID-19 vaccine webinar in conjunction with the Michigan Department of Health and Human Services and also Alpha Phi Alpha Fraternity Incorporated, the Ann Arbor chapter, on Thursday at 3 o'clock, from 3 to 4. They're going to cover everything in reference to what caregivers and seniors should know specific to the COVID-19 vaccine. Get your questions answered. We have a wonderful doctor who is going to be able to give great information. So if you'd like to register for that, you can go to tinyurl/AAA1B COVID-19 vaccine. But don't worry, because you're going to get an email from me with that information. And then also too, next month, we want you to join us for our second of a 3-part series, our Conversations for Caregivers, and it's going to be February 25th in the evening, and it's going to be on elder care coordination. So that's going to be another great informative session. Ms. Marilyn Lawson, who is awesome and very knowledgeable, is going to take you through how to set up an actual care team if you're caring full-time for a loved one and what that means and information that you should know. So you could register for that on the same link that you registered for this one. But again, don't worry, because you're going to get that information from me after this is over. So I want to see if we have any more questions. Oh, excellent presentation. Thank you. Can I watch the recording on YouTube? You know what? We have a YouTube channel for the Area Agency on Aging, and I think we're going to be able to upload this to it as well, because we are recording it, but you're going to get a link for this to have as well from me in just a few hours after this is done. So if we don't have any other questions, any other thoughts from Bethany?
I do want to share that our grief support program is open to anyone, regardless of whether you had a loved one on our service or not. And that is going to be emailed out to you, I believe, with the rest of the information from Chiara, from the Area Agency on Aging. So stay tuned for some information about grief support. We have some programs that are directly related to the COVID-19 pandemic. I know that there's been a lot of grief and loss in the last year that has happened during the pandemic. And so there are some special programs for that. We have programs for people who are widows or widowers, and they meet for lunch. Right now, obviously, we're doing this all virtually, so you can meet with other people that have a similar experience and have lunch together by Zoom. And we have some other groups as well geared towards younger people. So please check out those offerings. There'll be a link in the email that Chiara is going to send.
Perfect. Thank you so much. Again, Area Agency on Aging, 800-852-7795, online at aaa1b.org. We have a lot of information. I won't go over everything because you'll get an email from me, but thank you so much on behalf of both AAA1B and also Hospice of Michigan for joining us. We hope everyone has a great day. Stay safe, and we will see you at the next event. Thank you, everybody. Have a great day.
Thanks. Bye-bye.
Bye-bye.